help the primary care, get them to the right oncologist, get them to the right imaging studies, get them, if there's issues with prior auth, help all of that.
Hello, everyone, and welcome to the American Journal of Healthcare Strategy. Today, we're joined by a really special guest who's going to be talking about more of these really innovative population health approaches, intelligent approaches to managing CKD. Dr. Beth Malko, can you please introduce yourself and just give us a little bit of background?
Sure. As you indicated, my name is Beth Malko. I am a family practitioner by training. Before that, I was an engineer for a little while. I was in private practice in Connecticut and also worked in a rural health clinic in Vermont. And then I have spent a very long time, getting on to 30 years, in a variety of roles in both health plans and working for payer organizations in really to help make sure that members, patients are getting affordable quality health care.
Why did you make that kind of change throughout your career from engineering to medicine, and then even within medicine, as you mentioned, you've worked for a few different kind of angles, right? You haven't just been at one angle; you've done a few. Why is that? What has drew you to all of those things?
Well, aside from the fact that I obviously get bored pretty easily, realistically, I really always wanted to do medicine. My master's degree is actually in environmental engineering, and so very much about health and making sure that we weren't polluting the air and water to keep people healthy. So it was actually a fairly natural connection to go back into medicine, and in medicine, in family practice. It was interesting because I kind of thought I left engineering behind, but what I found was that I was really interested in system solutions, and I enjoyed. I did get to save some lives, and that was wonderful. But I looked at healthcare and I looked at how it was functioning in the U.S. and really feeling like, I could actually bring some of those project and process skill sets to play. Um, in more of a systems-based solution, really helping to improve overall healthcare and how insurers were delivering that healthcare. And so I was actually in a large group practice. We started taking risk as a practice group in the 90s in Medicaid. Maybe my lifetime claim to fame. We actually were successful and really did make some money and also did some incredibly innovative things that helped our patients really get better care and better outcomes. And that kind of got me hooked. I tried going back full time to practice because I really missed practice and then realized no, that those larger system solutions were much more interesting to me and probably the better use of my talents and skills. And it's been quite a ride. It's been really interesting and exciting and done some really fun and innovative and I think valuable things for members and patients across the different states that I've worked in.
I really appreciate what you're saying about the systems kind of thinking process when it comes to healthcare, because with primary care, with healthy individuals, middle aged and younger, there's not as much friction that occurs. But when you start adding things onto it, and whether that's SDOH, whether that's a complex condition, usually the two go hand in hand, as we've discussed on past episodes, you begin to really put strain on the existing system and you need to develop new ones. Why is that the case? Why, and where are you seeing that the most, where people need that complex system to really carry them through? What conditions are you really talking about?
Well, it's really any condition that is life-threatening, that is really impactful to your life. So, realistically, the healthcare system isn't designed to make the connections that need to be made. And primary care physicians are actually uniquely suited for that. And it's really a great deal of the strength that we bring to the table is knowing what's going on in the whole patient, right? So a lot of young women only see their OBGYN, which is okay, I guess, but it really is very helpful to have somebody who can make sure you're getting your flu shot and your tetanus shot is up to date. And, even young people do get horrible diseases, right? They get cancers, they get pneumonias, and you really need somebody who is on top of the whole picture. And really can make that family connection as well. So in my practice experience, I literally had 4 generations in my practice that I was taking care of, and really could understand where some of those friction points were coming from in a family to a member. Her diabetes was worse, or she wasn't managing her COPD because her 15-year-old daughter just got pregnant. She was so stressed out she couldn't think straight, right? So
Mm.
that ability that primary care brings to the table to really make those connections is enormously helpful. And if you look internationally at all of the first world countries, they are very, very much primary care based, and really, unfortunately, most of all of them have significantly better health outcomes overall when you look at a population than the United States does. So I'm a little bit bullish about the importance of primary care and how you make those connections, how you deal with the social determinants of health, how you deal with connecting. So you just get diagnosed with renal disease, and now you're going to see a nephrologist, and god forbid it progresses, and now you're going to need to have a graft put in, and now you're going to need to see a nutritionist because you need to change your diet. I mean, there's all, and like, how does that all work? How does that happen? How do you keep all the pieces and parts together? So what if you also have heart disease? And how
Mhm.
do we make sure that the cardiologist isn't prescribing something that's going to interfere with your renal disease? And so I think it's critically important to have that quarterback, that the PCP really is, especially both in people with complex illnesses and just in older people in general. I just read heard, I guess, a statistic yesterday that something like 89% of patients, people who are on Medicare over 65, are taking at least one medication, and many of them are taking many more than one medications, and so and seeing multiple specialists, and it, it is just a scenario that is ripe for problems if you don't have that quarterbacking in place. So sorry, I get a little bullish on primary care.
No, no, and I think what we see too is health systems invest a good amount in making their primary care work, in making it so that, uh, they're kind of a central, kind of repository for information and for data, but payers don't often have this, right? So, you invest in your EMR, your EHR, they implement AI solutions at the primary care level, which helps the physician, but payers often don't have that. And payers a lot of times can't tell what's happening from one specialist to another specialist to primary care. And that's very difficult. But at the same time, it seems like the complex conditions in specialty care is costing payers 10, 20 fold what they're spending on primary care. And so I guess it's concerning that you're saying that the root of a lot of the fixes is primary care, but we don't see our payers who are responsible for paying for our healthcare really spending in that area. Why
Well,
is that? And where do you think we go from here?
And I'm not sure that's entirely true. Actually, most health plans have been continually, year over year, increasing the reimbursement rate to primary care
Mm,
while holding specialty rates flat. Now, does that make up for the baseline difference? No. And that actually comes out of MedPAC, because MedPAC sets the CMS rates, and they definitely are very specialty based and focused in the rates. But again, MedPAC too, over a number of years, has been holding the specialty rates flat and increasing the primary care rates. So I think um, health plans do absolutely recognize the value of primary care.
mm,
Many of them have entered into risk based arrangements, and they can be anything from simply upside rewards for improving the health of the member, both in terms of quality and in terms of outcomes,
mm,
but also into full-blown risk arrangements where a primary care group is getting a percent of premium risk, and many of them were sophisticated health plans, and this is widely used in California. We're starting to see much more of it in Florida. In fact, in South Florida, you see a lot of it. Massachusetts has had risk-based arrangements for years, and providing the primary care physicians the tools to actually help this. And it's interesting that you say, that, and I talked about the split about care is happening over here and care is happening
Mhm.
over here. In fact, frankly, the only one who knows what's going on is the health plan, because we see all the claims, and it's an
Mm,
area that health plans are building provider portals that are really helping to create some of that information flow back to the primary care physicians. And so, both on the, I frequently say to primary care physicians, the patient comes in, their hypertension is still not controlled, and so you switch them to another antihypertensive. You probably should have called me first, because I could have told you whether or not they were actually taking their
mhm,
antihypertensive, because I can see how often. So let's say you've prescribed an antihypertensive twice a day, and I see that they're only filling that antihypertensive every 2 months. Well,
mhm,
duh, they're only taking it once a day. So I actually know, as a health plan, more about who the patients are seeing and where they've been admitted. So if you're admitted, you're traveling internationally, you're traveling across the country, you're admitted to a hospital, that's probably never going to get back to the primary care physician,
mhm,
but it gets back to me as a health plan. So, in fact, I think many of the health plans are becoming much more cognizant of the capabilities they have to actually share that kind of information with primary care physicians. Is it perfect? No. But I think it really is important to understand that health plans acknowledge that they have more information than anybody realizes that they have, and that increasingly we need to be able to share that. Now, there are some federal rules that
mhm,
make sharing certain information problematic. So you can't share behavioral health information, you can't share substance abuse information, and you can't share HIV information. Um, and it's a challenge, and I think there's a lot of people working on that. So it will never be perfect from a health plan perspective, but I do think that the health plans are actively engaged in sharing more information. And I actually think that's one of the things that Health Map has been very effective in doing, is actually engaging primary care physicians
mm,
about how to help manage renal disease and how to make sure that they're making those connections with the nephrologists. So I think that there are other scenarios like that, but it's actually one of the things that I've found unique about Health Map is lots of um, clinical partners or vendors work with primary care physicians on diabetes, on this or that, but on really actually being working on that connection between the nephrologist and the primary care physician. You don't see that very often, and I think that's really one of the strengths that Health Map has brought to the
mm.
table. I think it's been very successful for them, and was actually one of the selling points for me to work with them.
And that's what I wanted to ask was you've laid a good foundation. So the data is definitely on the health plan side with accomplishing this issue. The funding has, as you mentioned, started to turn, and so the attitude is there, but there's still this struggle. And we've seen a big rise in point solutions with AI, right? Everybody offers a point solution for everything. Even talking in our past episodes, I was talking to both Tom and Eric, and I've said, you could have 1,000 point solutions for everything that's offered. And so that kind of makes me ask this question, which is when we're selecting a vendor as a health plan, how do you select the right vendor and not get tied up in a single point solution or get tied up in something that's not actually going to work and help your patients? How do you make that judgment?
Yeah, so there's a number of things I think about when I look at a potential vendor, and in fact, I think the language I use is really important, because I really don't. I'm not interested in working with vendors. I'm interested in working with clinical partners,
Mm,
and I think that's really important for a number of reasons. So when I look for a vendor or a clinical partner, I'm looking for someone who brings a solution that is a health plan I'm never going to find by myself. A health plan is not going to be able to, unless you're United or your Elevance, and even they are unlikely to have a staff of oncologists or a staff of nephrologists or a staff of cardiologists. And if you think about each of those, they'd have to have, like 20 specialists and have to have, a staff of multiple ones. That's not realistic. That's not going to
Yeah.
happen. So we're looking for clinical partners who bring something to the table that as a health plan, especially a small health plan, but even a medium size or large health plan, even a jumbo, I can't really bring to the table. I am looking for a partner. I am looking for someone who is in some way, shape, or form going to have some skin in the game around outcomes. So the old model of working with vendors was
Yeah.
very much where you contracted with the vendor. They promised that they would do X, Y, and Z and save you X number of dollars. And you signed a contract. And in the contract, you put some SLAs. And the SLAs were how quickly they'd answer the phone, how many calls were abandoned, how many members they might engage with. But there were no KPIs that said these are the outcomes we're expecting. We're going to see a decrease in ER utilization. We're going to see a decrease in hospitalization. We're going to see an increase in quality scores, right? So it
Yeah.
was very transactional and not based on a collaborative partnership and an outcome. And so I think that that model has shifted dramatically nationally. Every place I've been in the last 15 years, probably, it's really been about let's develop that partnership. And I'm not necessarily saying that a clinical partner has to be at full risk, although there are partnerships like that that are wonderful. But at the very least, those fees that you're charging to create outcome X, Y, and Z have to be at risk to show that you are in fact achieving those outcomes and that we have KPIs that are really measuring those outcomes. Because, I can tell you about vendor after vendor where,
Mhm.
wait a minute, you said you were going to reduce our utilization of CAT scans, and I'm not seeing it. I'm not seeing any reduction at all. And then, you start to get into the story about why that is. I'm like, no, I just want to see the reduction,
Yeah.
right? That was the idea here. And so, to reiterate, I want to see a capability that I, as a health plan, do not have. I want a clinical partner. I don't want a vendor. And that clinical partner really has to have some skin in the game. It has to be measured on the things that matter. Not, yes, they have to answer the phone on time. Like they're still in
Yeah.
there. I'm not getting rid of those, right? Um, and there has to be a sense of collaboration, right? So in my past experience, I go back to a sleep vendor that we were actually the first ones to use this sleep vendor, and it was just all heck was breaking loose in Massachusetts at the time. And I would have this sleep lab director, and she had my number, and she called me weekly. And this is happening, that's happening, the other thing is happening. And the leader of that, they really were a clinical partner, would come back within an hour and give me answers to every single one of those issues and say, by the way, I already picked up the phone and spoke to Dr. So and so, and we're going to move this forward. That's what you're looking for. If you really need to have a partner who, and again, I go back to that word partner, who is going to be collaborative, who's going to work with you, who's going to acknowledge that everything isn't going to go swimmingly, that, at an implementation, health plans make mistake, partners make mistake, that we're going to work through those mistakes, that things are going to arise that were not anticipated, and we're never going to see the hand. We're always going to have that collaborative discussion. So those three things are absolutely
Mhm.
critical to me. And then of course, I need to have good reference checks where I'm able to talk to a health plan that's similar in size and shape to me, that has worked with this clinical partner and has seen that collaboration, has seen the kind of outcomes that I'm looking to see. So I think it's a very different approach that you have to take in terms of finding someone. I think two other things play a role, and you hit on the first one. Are you working with that vendor in another? place or with another. So, if you have a vendor who you're doing end of life with and they also have an oncology program, wow, why would you bring in a different vendor to do oncology? Like, you would want to connect those. And hey, if that vendor also has genetic testing, that could be really helpful, right? So,
Right.
yes, there's no question that minimizing, you know, multiple point solutions, especially all around a single disease state, is cuckoo crazy, right? You don't want to do that. So you really, if you have a good clinical partner and they have another service that they can offer and that they have had good results in, yes, that is going to be very important in your thinking about vendor selection. Not definitive, but very important. And experience in your geography. You've worked in one state, you've worked in one state. Every state is different, some remarkably different. Some are pretty, run of the mill. There are some real outliers out there, and understanding how Medicaid works in that state, understanding, the different CMS regions have different LCDs, local coverage determinations. The fact that they've worked in your geography successfully at work, your providers, like they've already worked with your providers under another health plan. That is important. Again, not definitive, but important in making a vendor selection, or especially in finding a clinical partner.
So, based on what you said, that sounds really great, right? It makes a lot of sense. But I feel like it requires an executive level of input and really a clinical level of input from the health plan. And what I mean is that when I'm just choosing a vendor, like a software as a service vendor that a lot of vendors utilize, that goes through my vendor management team. I probably never see it. Usually it goes up through the CFO's office. It's usually using requisition forms, because it's not a partner, right? Like you're saying, this isn't really a person or organization. It's more of a thing that you're buying. But in this case, you're saying it's a clinical partner and you need that involvement. One of the pushbacks that I might get from, the C-suite in that is, that sounds like a lot of work. I don't want to deal with having to get involved in my vendor selection. Do you think you could maybe share why doing that extra work up front is actually way more valuable for you as an executive at a health plan?
Yeah, I mean, look, hands down, that the chief medical officer is part of the C-suite, and any clinical vendor decision making ultimately really has to have
Yep.
a strong thumbprint of the chief medical officer. And generally, the chief medical officer is running your total medical expense committee or cost of care committee. Most places call it a total medical expense committee, and that construct around the chief medical officer being responsible for cost of care, being responsible for quality of care, i.e., affordable quality health care. That's their job, right?
Yep.
And their job is to do all the vetting, to run that through the total medical expense committee, to make sure that all of those bits and bytes are ticked and tied, so that when it comes up to the CFO, to the CEO, to say, hey, we're ready to go forward with this contract, and here's why, that you're hiring a CMO who is data savvy, who can run a total medical expense committee, who can bring you a package, frankly tied in a bow, that is
Mhm.
is not a lot of work on the part of the CFO or the CEO. But it's like, oh, well, that makes a ton of sense. You basically told me you're bringing a partner who, if I can go to a CEO and say, okay, so this vendor is guaranteeing with their fees this outcome, or taking a capitated rate that's going to increase over time. And it's sort of free money, and it's sort of a give me for our members. It can only help our members. You don't get a lot of pushback.
Mhm.
I think that the CFOs in particular, but CEOs as well, are kind of done with vendors on the clinical side, right? And so
Yep.
that idea of, wait, you're bringing me another vendor who I'm going to pay a fee, and they tell me they're going to do something, and then it doesn't happen, like we need to learn. And so my response is, yep, I agree with you completely. I would never hire a vendor, and I would never hire a vendor under those circumstances. This is completely different. And it does take some work on the CMO's part to really get the CEO and the CFO to understand this very, very different dynamic, right? It really is, I hate that paradigm shift, right? I hate,
Right.
sea change, paradigm shift. We've all heard it so many times we really cringe, but it is. It is a fundamental paradigm shift that says we are not hiring another vendor. We're hiring a clinical partner who is in as deep as we are in getting the outcomes that we need. And by the way, these outcomes really matter to the member and they matter to our bottom line.
Yep.
Um, and I actually, yeah, the first couple of times you have that conversation, it's hard. But once the CMO has shown that, yep, that's what they're doing, and the vendors they're bringing in are delivering, it doesn't become a difficult conversation at all anymore.
So you just have to do it, that get over the hump of getting
Absolutely,
traction.
right?
Yeah.
Nothing succeeds like success, right? So,
And as a CMO, after you've implemented this a couple times, are you saving time down the line? Because right now, some CMOs, a lot of times it falls under the chief data officer or tech officer. They're putting out fires constantly when it comes to vendors. I'm assuming that goes away when you start using partners, or at least not as much.
yeah, not as much, right? I don't want to say goes away because, so I love that you're talking about the data piece because I think that is a huge issue and it is a huge hump that has to be overcome every single time. And the advice that now I'm working as a consultant I give to my health plans and that I used myself is here's the data set we have that you will be getting. You'll need to figure out how to use this data set. We are not going to spend hours, days, weeks creating the data set that
Mhm.
you want. Here's our data set. If you want to work with us, you're going to have to figure out how to use it. And it's remarkable how often that works because you're saying, look, I can't be creating a completely different data set for every single partner and it's not even the partner, right? When you've sent an RFI out and you're comparing three or four potential clinical partners, you can't be set creating three or four different data sets. Like that isn't going to work.
Mhm.
So the first time the IT team hears you say that, they're like, oh, wait, I like her. Let's chat some more about how this is going to work, right? And it does work. um, and I do think it's very important to learn from each implementation because with each implementation there is some IT glitch. It's a given. It turned out that we didn't send this over, or and it frequently is a glitch on the health plan side. It can also be a glitch on the partner side. But really, if you've already picked a partner who you know is going to be collaborative, then you can get over those glitches. And, the more you do this, I've been doing this for 30 years, the more you can see right away, oh, stop, we're not going to have this fight. We're going to figure this out. Here's what happened. We understand what happened. Let's figure out how we can fix it jointly. And if the partner isn't willing to have that conversation and be part of the fix, we won't renew with that partner.
Yep.
Or if it's early in the stage, we'll stop the implementation and end the contract there. So I think it's experience and expertise in working with the IT team and understanding that this isn't a pure clinical solution. In order for the clinical solution to work, you have to have accurate interfaces and exchanges of data, or else it's not going to work. And that's as important to this as anything else. So your
Yeah.
vendor management team is wonderful. You need one, but they have to really work intimately with the clinical team and they have to be connected with the IT team. I was very fortunate when I was at Florida Blue, the team that was actually supporting as project managers or TME committee actually came out of the IT
Mm.
shop. So a lot of those barriers we didn't have to deal with because they spoke IT, right?
Right.
And so I think it really is important to learn to speak IT pretty early on.
I think that's important. It's a really interesting thing I did not even think of, because when a friend I met at HIMSS, his whole firm does that for health systems. They move the data, alter the data, and prepare it for their vendors, and that's what his whole company does. Is just the changing around of that. And so I think it's interesting, the hidden costs that could be maybe removed. And I'm thinking, legal costs, litigation costs, all kinds of things that people experience. I want to shift gears from it though, and ask a question based on your primary care experience. And that's because we've spoken with specialists on how to improve specialists. We've spoken with, individuals on how it can improve their kind of personal lives. But from a primary care perspective, how does a partner with a health plan like Health Maps benefit you as the provider providing the services?
Well, your initial response is, yeah, no, not interested. Thanks anyway. Because the last thing you need is the last thing you need is somebody else telling you how to practice medicine, right? And that is the normal response.
Right.
And so it really, again, it comes back to that partnership. It is the CMO or the provider relations team who is reaching out to both the clinical leadership and the business leadership of the practices. And you start with your larger practices and work your way down to say, hey, you know that renal disease is a huge issue. And I, as a clinician, can say, hey, primary care doc to primary care doc, we're not very good at nephrology. None of us are. It's really hard. And it's something that, we struggle with. Most of us don't have a ton of CKD patients. We don't have a ton of ESRD patients. And what this clinical partner is going to really want to do is probably speak with you, CMO, speak with you, business officer, office manager, practice manager, and really figure out how we can get in there and get you guys situated such that you're identifying members with CKD early in the process, you're getting them off to nephrologist early in the process, that we're helping you, that knowing that we're there, we're case managing the members. If the member is getting worse, if they don't like their nephrologist and they need a new one, that this partner is going to be there to help you. And ideally, you start with your at-risk PCP groups. And by the way, if we can reduce these costs, this is going to help you enormously. And
Yeah.
I will say that 90% of the time, that works really well. Having that conversation with a onesie twosie practice is probably not going to happen. They don't have the time in it, and it's just not going to happen. And so you do the best. You send them a letter. You let them know you're available. Provider relations is stopping in for something else. They're going to mention it. They're going to address it. But it's really, and increasingly, so many practices are large group practices,
Mhm.
that being able to connect with both a clinical leader and a business leader at the practice allows you to really make the case and then be available. So the clinical partner is being a pain, that clinical leader is going to call me and say, yeah, remember that clinical partner you talked to me about?
Yeah.
I got it. I'll fix it. We'll work it out. But you have to be available to be able to do that and to make those connections. You can't send a letter and say, oh, by the way, this new partner is going to call you and they're going to tell you how to practice
Yeah.
medicine for your renal disease patients. Yeah, no, that doesn't work. You have to do the work.
Yeah. That's so important too, as systems. I just think about the resource for the system perspective. When people onboard vendors to the payer, I feel like sometimes vendors are not treated as how they're going to affect, they care about their patients, but they don't always care about the providers in their network, right? And I don't think that's their fault. I think it's because it's another stakeholder, a more complicated stakeholder. But when you're using the partnership approach, it seems like you are taking into account, as the CMO of a health plan, how it's going to impact the providers of the community, not just the patients.
But, at the end of the day, health plans, we believe very strongly that our case management really helps to improve the health of our members and that our quality initiatives really help. It is the provider who is taking care of the patient. And
Mm.
our job is not to get in the way of that. And to the extent that we can, to provide them resources and support in order to do so. And it is in those very complicated patients, especially patients who, again, you've got an ESRD patient. They may very well, they're at higher risk for all sorts of complications. They're more likely to, you gotta be very careful about their immunizations. You have to be careful about the other medications that they're on.
Yeah.
You have to make sure they understand their diet. And it's a lot, and it's really a lot for a primary care physician. And to be able to say, we're here, we're case managing the member, we're reinforcing these messages, We're going to help be that communication between you and the nephrologist. We're here for you. That can actually be enormously helpful. Now, as a health plan, if you were to provide that for the cardiology patients and the renal patients and yeah, no, that's not going to work, right? So you can't be having 12 vendors who are calling a PCP practice and saying, "Hey, we can help you with this," right? Um,
Yeah.
that doesn't make any sense. But I think nephrology and oncology, in particular, are kind of two outliers. Once a patient is diagnosed with cancer, they go off to the oncologist. And yes,
Yeah.
they're going to show up in the primary care office, but the oncology care is happening at the oncology location with the
Yeah.
oncologist. The and half the time they get admitted for a problem. They have febrile neutropenia. They get admitted to the hospital. The primary care doesn't even know about it.
Hmm.
The same thing with nephrology. I mean, at the end of the day, I don't think there's any question that getting a patient to a nephrologist early in their CKD course can be enormously helpful because there are so many bits and pieces that have to be sorted. The meds have to be sorted, the diet has to be sorted, um, the management of the complicating conditions like hypertension and diabetes have to be really pulled together. And working closely with the nephrologist is critically important. God forbid they move on to ESRD again, they disappear into the nephrology space. And so I think of those two disease states as being such that yes, for oncology care, we can help the primary care physician early when the patient is just being diagnosed, help the primary care get them to the right oncologist, get them to the right imaging studies, get them, if there's issues with prior auth, help all of that. Once they're with the oncologist, we can continue to case manage them. When they're done with the oncologist and they come back to the PCP, we can step in and help again. But again, not necessarily working as closely with the PCP. Nephrology, again, sits out there alone. The data is pretty clear. A lot of early CKD, especially, 2 and 3, where it really starts to matter, isn't even identified by primary care physicians. I had a similar situation personally. I don't have renal disease at all, but I was taking a drug that was dehydrating the heck out of me. And I
Hmm.
said, hey, my GFR isn't really, no, I'm a doc, right? My GFR isn't really where it should be. Should I see a nephrologist? Oh no, just drink more water.
Yeah.
And 8 months later, when we retested, and I looked to be in an acute renal failure, like,
Yeah.
and it was just
Right.
dehydration. But the point is that,
Yeah.
I think as primary care physicians, there are so many things we're worrying about that catching that early CKD and then changing the medications and worrying about protein loads and worrying about just the controlling the diabetes and the hypertension much more aggressively in a patient who's showing signs of early CKD. That's a lot. It really is. And so, that support to say, hey, nephrology is really hard and we're here to help you. If you don't want our help, that's fine. We're still going to help the member. We're still going to work with the nephrologist. But if you want our help, we're here. That was a very compelling argument to me as a primary care physician.
Yeah. Especially for a high friction, high complexity, requiring much more education, in that specialized area just to be able to treat the disease. I think that's difficult for health systems to manage as well. From a health system perspective, is how do you move patients from primary care to these specialties? I know in neurology, it's been a big discussion. Can we try to treat migraine patients in primary care more before shifting them? I think that's an example of an area where it's easier. It's easier to do that. And then you have the really high complex ones, like you mentioned, oncology and nephrology. It can't be done. And so I see this as a resource for primary care, but also for the health system. And that's excellent. Thank you, Dr. Malko, for coming on and discussing this from the perspective of a primary care physician, a health plan executive, and an engineer as well. We heard quite a bit about systems engineering in there, and I'm reading a book on it right now, so I picked up some terms. So thank you for this really in-depth conversation, and I hope we can have you on again.
Oh, I'd be delighted. It's lovely chatting with you.